Welcome to On Becoming a Healer with Saul Weiner and Stefan Kertes. We're two physicians reflecting on how better self-knowledge makes us more effective in medical practice and education, and how that's essential to joy in being doctors. We do this in this podcast by telling a story and reflecting on themes of judgmentalism, engagement, boundary clarity, ego, and caring.
Thanks, Stefan. What are we talking about today?
Well, in contrast to our first few, I'm going to be the one telling the story.
Oh, that's great. I get to rest.
Yeah. So I want to talk about a case where I was not the direct caregiver, but I got to review the record. And it's a case that involves prescription opioids for pain.
Okay.
I think it raises important questions about how we engage with patients, how we listen, and how we handle different perspectives in care, particularly when we wind up at odds with the patient on what to do next.
Sure.
Let me make 2 points in starting up. One is that we should take a note from our friends at another podcast, Curbsiders. We're going to say this case happened at Kashlak Memorial Hospital, which is the imaginary hospital used on Curbsiders. That way we'll avoid any violation of privacy.
I guess plagiarism is the highest form of flattery here.
Yes, and we admire those guys greatly. Actually, not just guys. The other thing is that even though this is a particular story, it's typical of a great many that I've seen directly and where I've received stories from patients or reviewed records before. So it's not entirely unique, which is why it's interesting.
Great.
So I was asked to look at a record after an unfortunate event. And in this case, the lead up to the unfortunate event involved an effort to reduce the doses of prescription opioid pain medicine that a patient had been on for a very long time. Mm-hmm. And this was a case being managed jointly by a clinical pharmacist and a doctor. And here's how it read. The patient was a man. He was in his 50s or early 60s, as best I recall, and he had a number of significant medical problems and some history of mental illness, not necessarily super severe, but definitely post-traumatic stress disorder in remission, or at least not as severe as it could be. And he had a number of pain conditions that were mostly related to back and other joints. He'd been on prescription pain medicine for a long time, probably a decade. Those included 2 different medicines.
Okay.
One was methadone, which often is used to treat addiction, but can be used to treat pain. And he was also on either oxycodone or hydrocodone, one of the more typical sort of short-acting opioids. And he was meeting regularly with a pharmacist who was proposing to him that he needed to have his doses brought down. Those doses, when you sort of try to calculate what they were equivalent to, he had been at a high dose relative to the CDC's guideline of 2016. I think that's about 90 morphine milligram equivalents. So gradually, the pharmacist was meeting with him and proposing reductions, and a doctor was also reviewing the chart and signing off and helping write the prescriptions. And those reductions were proceeding over a period of a few months.
Sure.
And the patient started to say, I'm having a hard time with this. My pain is getting worse. I'm not sure I can handle it. The pharmacist, as I recall, actually temporarily paused a little bit on the dose reduction and then a few weeks later continued. As the pharmacist continued and the doses really got quite a bit lower than they had been before, there's kind of a split in the various clinical notes that were written about the same patient. The psychiatrist notes from the same era featured the patient saying, I'm in a lot worse stress and I'm feeling really bad and I'm not sure I can survive what's happening with my pain medicine. They're being reduced so much, I just don't think I can make it. Mm-hmm. The pharmacist's notes said that the pain medicines were being reduced and the patient had some concern and that the patient agreed to a further reduction and then showed a map for how the doses would be reduced over the next few weeks down to 0. At that point, there's a little bit of a discrepancy between the 2 sets of notes, but the events became very clear because within a few weeks of that visit, the patient turned up in the emergency department with intoxication. And the report to the emergency department was, I couldn't handle what was happening to my pain meds. I got upset, so I took all of my remaining pills and some alcoholic beverage, I think it was vodka, mm-hmm. and a sedative pill, specifically in the benzodiazepine family, like Valium or Klonopin. And the patient was essentially treated in the emergency room and I think admitted briefly to the hospital for a toxic combination of sedating substances from which they could have died, but they didn't.
So if I understand correctly, this patient had not been drinking alcohol or taking sedatives or benzos while he was on his baseline dosage of those 2 medicines you'd mentioned, the methadone and the oxycodone or hydrocodone. This relapse into alcohol use and sedatives and benzos only occurred when he was forcibly taken down on the medications that he'd been taking previously. Is that correct?
Exactly. there was some past history of alcohol problems, but it had not been current. It was a remote thing in the years past, and there had been no evidence of that. That wasn't why they were reducing the prescription pain medicine. They were reducing it because of a belief that the reduction in dose would make the patient safer. And as those doses went lower, the patient reached some sort of crisis point where they took the last set of pills they had all at once and drank and used sedatives, which they weren't even prescribed. They got from someplace else.
So I think the point that Bear's making right now is that we had a patient who was doing well. They were in a sort of what I call an equilibrium state on the medications that they'd been taking for their chronic pain. And while they are not necessarily medications or dosages that one would have put someone on in the current environment, as we all know, a lot of us inherit patients or have patients who are on these doses of medications for many years. And this was a patient who had been doing apparently quite well. He wasn't using other substances. And the point you made is that there was a quote-unquote belief that he would be safer if he was scaled down and ultimately taken off of these medications. And that seems to have been what precipitated this unfortunate event. And it sounds like there was some warning signs that he was telling his psychiatrist that the term you actually used was, "I'm not sure I can survive this."
Yeah. Exactly. So the patient was desperately fearful, at least in their expressions to one of their caregivers. One of the fascinating things about this is that the notes from the different caregivers don't line up. And I've seen this before. This is not a unique thing. This challenge of one clinician reporting that changes in opioid pain medicine are represent a stress, and another one, very often the one who's managing the reduction, reporting that the patient has some concerns, but that it's tolerable and manageable. That's a discrepancy I've seen many times.
Do you have any idea why, I know I'm asking you to speculate, but why that might have occurred?
Well, this is speculative. I think that in healthcare, at least in the United States today, there's both a real belief that if we could just reduce these, the patient really will be better off. And that belief itself can potentially get in the way of hearing a patient when they say, you know what, I think what you're doing here is not making me better off. So that would be the first reason I would think that might be the case, is a sincere belief that this is really good for you. So what you're saying cannot really make sense. But
now, if the pharmacist was documenting that the patient was okay with the taper, whereas the patient apparently was telling the psychiatrist they weren't okay with it, what do you think was going on with the pharmacist? Was the patient saying something different to the pharmacist?
That's a fascinating question. And of course, we're subject to the reality that all I see or saw were notes written by others. And so one of the big challenges with medical records is that we know that whoever does the care, whether it's doctors, nurses, or pharmacists, they don't document everything that is said. In fact, it's probably impossible to do that. You know, one of the stories that comes to me from patients elsewhere in the country is that if they've been on pain medication that's prescribed for a long time, they are so afraid under the current environment that those medicines will be stopped that they do everything they can to appear agreeable to the person who seems to be in charge of the prescription. So the person who is in charge of the prescription could conceivably stop it immediately. So it is at least possible that the patient really did present as positive a face as possible to the person managing the prescriptions, which in this case seemed to be a team of a pharmacist and a doctor, while presenting a potentially more authentic story to their mental health provider. I should specify that all parties could see each other's notes. These were not two separate providers who didn't share records.
Right. And obviously, in hindsight, it appears that what the psychiatrist was documenting was more accurate in terms of what was going on inside the patient's head, because after all, they did crash. They did end up in the ED in this really bad situation. So I think the communication with the pharmacist does not appear to have represented what the patient was actually experiencing.
Absolutely. I mean, I think if a patient is telling their psychiatrist, I'm not going to make it, and then they have an event that almost results in their death, we have to assume that what the patient said to their psychiatrist was accurate. And if the patient said, you know, I think I can handle this to the pharmacist and the other doctor, that was not the accurate story.
Mm-hmm. And I think, you know, you started out by saying that you picked this case because it's not because it was an unusual event, but because in some ways it is almost typical of a lot of what we see. And I'm not an expert on this whole topic of addiction, but some of the things I've learned, apart from talking to you, is that while we know that putting people on high-dose opioids for chronic pain is a bad idea, and there's lots of evidence to show that it's had enormous tragic consequences for countless people in the country, we don't have a lot of evidence that forcibly taking people off of opioids opioids who are in a stable state, basically who are functioning well, is safe or beneficial. Is that right?
Absolutely. Because at the moment that it's happening, they feel very often, not every single person, but most are going to feel violated. Most are going to feel that they are not being heard. Most are going to feel harmed. Now, I should caution there are doctors who are very good at this conversation and can create a space where the patient essentially agrees on a provisional basis to try that reduction consensually. It's not always completely black and white. If the doctor says, I think this will help you, I want to start this, please work with me. That is a journey that a patient and a clinician could take on. However, that's not so common.
I think that's a great point. And I want to make a very subtle distinction here between two different ways that can occur. Ideally, when that occurs, the physician is doing it in a truly collaborative way, meaning that they're not essentially just really slick and charming and yet pretty much hell-bent on weaning the patient down no matter what. They're truly collaborative. In other words, they mean what they say. Let's work together on this. How about if I try taking you down a little bit, and if you're having a problem, here's my page number, just call me. That I would consider to be a truly collaborative relationship. I would distinguish that from a situation where the physician is essentially kind of, for lack of a better term,
bulldozing.
Yeah, bulldozing with charm, if you understand, but still hell-bent on getting the person down. And I think that's the distinction.
Yeah, I agree with you. And the reason that distinction matters so much is because there are both clinicians who proceed from a very sincere belief that the bulldozer is itself a beneficial way of proceeding. And there are also clinicians who proceed with the belief that they are under threat or pressure from the healthcare system, that if they do not do this, they could be found liable at a future time.
Mm-hmm. So let's just, for the sake of argument, let's just set aside the external pressures for a moment, because I know they're real, but I want to look at this from the pure standpoint of what is best for the patient. And I think what we're saying is that given that there is an absence of evidence that forcibly tapering a patient who is doing well on a stable dose of an opioid will benefit them. I think this is an excellent context for collaborative and shared decision-making experience where the physician and the patient are genuinely operating in an environment where there's an unknown. It's not clear what's going to be best for this patient. And I think the physician can share that information with the patient and say, look, we know that high doses of opioids can be harmful to patients, particularly the dose that you're on. We don't know if taking you down on this dose is going to benefit you if you feel that you're going to do poorly, but we need to work together to decide how we're going to proceed. And in other words, to do it in a truly humble way, meaning that there's no attempt to strong arm the individual. There's just a shared understanding that they're operating in a kind of knowledge vacuum. And I think that's the ideal model that we're talking about here. Is that a fair summary?
Yeah, I think when we don't know and you have a person who's stable and functional, that really is the optimal thing. But it does require a certain modesty on the part of the clinician to be able to say that. It's not super common.
Mm-hmm. And I think that what's troubling in the story you related, to me at least, is that it appears as if the patient may have made a decision to pretend they were okay with weaning because they sort of felt like this clinician was going to do it anyway. And again, we're just speculating here. We don't really know what was going through their head. But in an ideal environment, they would have been able to say the same thing to the psychiatrist and the clinical pharmacist.
Yeah, if you're going to carry out a process or a procedure on a patient and they know internally that they might not survive what you're going to do, wouldn't you want them to tell you, I don't think I can survive? I mean, I would feel terrible to not have heard those words. And I would want to bend over backwards to say, look, I need to know what reservations and concerns you have about this because I don't want to inadvertently create a situation that causes a crisis.
Yeah. So I think, just to maybe wrap up here, I see this as an excellent example of where genuine engagement is what you're looking for. And when I've talked about engagement, I've sort of emphasized this idea of two people being on a level playing field, meaning that the doctor doesn't have an agenda. The doctor doesn't see themselves as knowing what's best because there really isn't an evidence base for this very specific situation. And so this is really genuinely a partnership where there can be openness and planning. And of course, the physician can document what the patient's preferences are, and they can document what the evidence shows or does not show. And of course, by doing so, they're also protecting themselves to some degree by documenting the logic of their decision-making and the reasoning behind it.
I agree. But in order to do that, we have to then agree that individuals who have potentially some disability, some pain, and who have a dependence on medication, even if it's not addiction, that these are people who merit being heard and respected as authoritative to the same degree that we as the clinicians merit being heard and respected as authoritative. And that's humility. That's fundamentally about humility.
Now, I realize that in this conversation, we have not talked about the external pressures on physicians that you've alluded to and that are real. And that may have to wait until for a different session to talk about. But I also think there's merit in saying that one does need to separate that out from a discussion about what's ultimately best in the doctor-patient interaction and what's best for the patient. And we can almost say that the pressures that are on the physician, to the extent that they may not be in the patient's best interest, I believe that it's the job of the physician to shield the patient from those pressures.
Yeah, I would agree the same. And it's probably going to take a few more conversations till we figure out how to equip clinicians, whether they're pharmacists, physicians, nurses, to know how to manage those pressures so that patients are properly protected. But that's where I would love to move forward in the future.
Well, Stefan, thanks for sharing that case with us. I think it illustrates a lot of important points that we like talking about on becoming a healer.
Thank you, Saul, for the chance.
Bye-bye.